Good evening, everybody. I'm Nilesh Bokadala, one of the chief residents in otolaryngology. Thank you for the opportunity to speak to you all. Today I'll be discussing several key concepts in the field of patient safety, which is a topic of great personal interest to me. I first became interested in this topic as a senior in college when I had the opportunity to have dinner with Dr. Atul Gawande, who was speaking at my university. And in medical school, just by chance, Dr. Bob Wachter, who's another giant in the field of patient safety, happened to be the medicine attending during one of my rotations. And so I had the opportunity to spend some time with him as well and learn about his views on patient safety work. And these two individuals instilled a belief in me that quality and safety work is really integral to the care that we provide for patients. I have no financial disclosures. And my goals for this talk are to help us all develop a shared vocabulary of patient safety concepts and highlight some key factors that I think are understudied in otolaryngology. I'll describe some examples of how these patient safety concepts affect otolaryngology patients. And my emphasis during this talk will be on easy to implement strategies that do not require a major institutional project or significant time commitment to put forth. The inspiration for this talk came from a mini kind of personal field study that I did during residency, where for a brief period of time I decided to just count how many near misses or misses that I noticed while I was on service. And I realized just how many potential patient safety events occurred during that time. And not all of them were the dramatic error, but several were significant. And I noticed many arose from patient safety topics that we don't always talk about in our QA conference. And the reason for this is that they were occurring in contexts for which there's really no formal mechanism to discuss. For instance, they were occurring either in a cross-institutional fashion or a cross-departmental fashion, or the initial event might have occurred in the past and the sequelae were only felt, months or years down the line. And I firmly believe that reflecting on our day-to-day experiences can help identify avenues for improvement. So I will just give a very broad overview of some of the events that I noted during this period of time. And we'll go into a little more detail on a couple of them. During my period of observation, we had a patient who presented with unresectable head and neck malignancy. And on chart review, it was found that an early lesion had been noted on a head CT read 2 years prior with follow-up recommended but never ordered. There was a case of missed complicated frontal sinusitis on MRI. There was a trach patient who was brought in from a facility for hypoxia that was thought and assumed to be due to trach dislodgement, who underwent an awake fiber optic intubation, and then only to find that the etiology was actually COPD. There was a patient who visited on post-op day 1 for a low-grade fever after sinus surgery and got a full sepsis workup and unnecessary antibiotics. There was a case of delayed recognition of facial nerve paralysis and more. And so with all of this in mind, as I mentioned at the beginning, I want to focus on 3 kind of understudied areas particular to our field. And I've selected these topics based on personal experiences throughout residency, which have highlighted these as root causes of so many near misses and misses over time. And each addresses a different level on the organizational system of healthcare. So the first topic will be on cognitive biases, which really goes to the individual level. The second will be on teamwork and communication, which moves into the team or group setting. And the last will be on transitions of care, and specifically on discharges on the system level. And before we dive into it, I want to just provide some preface and caveats. First is that identifying details have been changed in all cases to preserve confidentiality, and that not all errors caused harm in every case. Second is that my intention with this talk is not to Monday morning quarterback the providers involved in these cases. And in that regard, I will say upfront that I am by no means immune to these types of errors. And a great deal of my interest in this topic is because I know that I commit these errors time and time again, and I'm interested in finding solutions to that. And lastly, and perhaps most unique to most patient safety talks, I promise to you that I will not use any aviation examples today. So beginning with cognitive biases. Probably the most popular model that's really been in the press over the last decade or so is that espoused by Kahneman and Tversky, which basically divides cognition into two systems. System one is the fast, automatic, intuitive approach. And an example of this might be, when we learn the ear exam as medical students and then starting out as residents, that over time becomes more of a system one process where if you're an experienced clinician, you can glance in somebody's ear and get a sense of the entire ear exam and what you're looking at. But when you first start out, it's really a system two process where you're carefully studying the eardrum, you breaking down the components, what's the malleus, what's the light reflex, and analyzing that process. And that system two thinking is an analytical form of thinking. It's slower, it requires more time, and it relies more on reason. And I think it's important to make the distinction that one system is not necessarily better than another. It's really more that misapplication can be problematic. And so, for instance, if you use system one thinking, fast thinking, to diagnose a new patient who presents with complex constellation of symptoms and years of extensive workup, then you probably should be using a slower modality of thinking, your system two thinking. But by that same token, if you use the analytical thinking mode heavily to diagnose a slam dunk case of otitis externa, that's inefficient and cognitively taxing, and we rely on system one thinking throughout our days to get through all the tasks we have to do. Sleep deprivation and fatigue and heightened emotional state all increase our use of system one. And cognitive biases have both adaptive and maladaptive functions. And before I go on, I just want to acknowledge that one important cognitive bias is implicit bias, which has rightfully gained a great deal of attention, particularly in recent years. And although I believe that implicit bias is an incredibly important bias to address, I think it's an important enough topic to merit its own full discussion. And so I won't be addressing it directly today, but I do want to acknowledge up front that implicit bias compounds many other biases that we'll discuss during this presentation. And so I'd like to start with a clinical example that I was part of. It was a 14-year-old male who presented repeatedly to the emergency department with vague complaints of malaise, headache, congestion, and at each visit he had low-grade temps, vital signs were otherwise stable, white count was normal or borderline elevated, and at his first visit he was found to be influenza positive and symptoms were attributed to an upper respiratory infection. Eventually, because he came back so many times in a 2-week period, at one of those visits he underwent head imaging, which was read as normal. And then he presented a week later to another hospital, now with fevers, a markedly elevated white count, and was found to have complicated sinusitis with intracranial extension. And on retrospect, the prior head imaging had indeed shown some of these early features. And so we often analyze, sorry about that, we've jumped ahead. We often analyze cases in QA conference using the Ishikawa fishbone diagram, which incorporates many factors like environment, patient factors, and so on. And this is an excellent method of looking at a case. But I think in this particular situation, there is another methodology that we could use, which is something called human factors analysis and classification system, which provides an illustrative way to consider this from a cognitive process standpoint. And so with an HFACS analysis, if it's felt that an error might have occurred due to judgment, you can subdivide that into what cognitive biases or implicit biases might have been at play, and you can use that as an opportunity for coding those biases for future study to determine whether there's any kind of systems level improvement or structural change that might be necessary. And so just as an example, I'll very briefly talk about some of the kind of cognitive processes at play in this case. One might be priming, which is the concept that exposure to a particular fact or stimulus influences our response to something else. And so in this case, the query for radiology during the initial imaging study was rule out intracranial mass. And they did indeed rule that out because there wasn't any on that. But the sinusitis that was clearly present was not noted. Another might be search satisficing, which is the concept that we have a tendency to stop searching once we've identified one plausible explanation. And so in this case, likely the diagnosis up front that this child had influenza led to a difficulty considering other possibilities, even in the face of repeat visits. And then finally, we might say that there might have been some anchoring in this case, which is also a form of confirmation bias. And that's overemphasizing an initial or first piece of information, which might be the initial diagnosis told to us. And it can also be other things, like if a colleague tells us that a patient is difficult or anxious, that too can cause us to anchor on a particular fact and disregard other facts that might be pertinent. So the list of cognitive biases can, of course, go on and on, but I'm just going to share one more that I think is vitally important for our conversation this evening. And if you heard this prior example, and like me, your first thought was one of a severe judgment on the providers who missed this, and you thought, just how could they possibly miss this? Well, this next bias is for all of us, and that is, I think, no better explained than from this quote from the comedian George Carlin, which is, have you ever noticed that anybody driving slower than you is an idiot and anybody driving faster than you is a maniac? And this bias, of course, is fundamental attribution error. And so this psychology definition of this is the tendency to overemphasize fixed personality traits in explaining a person's behavior and to underemphasize the importance of situational environmental factors. And we generally apply the reverse to ourselves. And examples of this really abound in medicine. You know, one might be the patient who doesn't take their medication regularly, and we're frustrated with them. They're non-compliant. But, I mean, speaking from personal experience, taking a medication more than once a day is really hard to remember, and I forget all the time. It might be the poor intern who doesn't edit the discharge instructions properly for a patient, and you think, how could they be so sloppy and careless, right? Or it's the ubiquitous OSH that misses the cancer diagnosis. These are all kind of ways that we apply fundamental attribution and assume that people just have these fixed, flawed personalities when there are other factors likely at play. So that's all well and good, but how do we improve on an unconscious process? I mean, that seems like a tall order, but I think there are actually several easy to implement strategies we can undertake, and I'm going to talk about these three in the subsequent slides. So the first is metacognition, which quite simply means thinking about thinking, and that seems simplistic, but studies have actually shown that that being aware of our thought process can really help mitigate cognitive biases. And so there was an interesting study done where they took 42 internal medicine residents and they asked them to review 16 cases and make a diagnosis. And for 8 of those cases, they were just given the case presentation and asked to make the diagnosis. And for 8 of the cases, they were given a couple of prompting questions that caused them to reflect on the diagnosis they initially arrived at. And it was interesting, kind of in line with what you might expect. For simple cases, which is the kinds of cases where system 1 thinking is perfectly adequate, there was no difference in performance. The people achieved the same rates of the correct diagnosis. But when it came to complex cases, residents were able to improve their accuracy in those from 14% to 42%, just with a couple of prompting questions. And on that note, I want to just share an example of a case that I was involved in the past year where awareness of these biases honestly made a big difference in the patient's care. And so we had a patient who had cancer of the unknown primary, and we took them to the OR to do a DL with biopsy, possible tonsillectomy, and so forth, to try to find that. We had just completed the DL, and there were no candidate targets there. We looked at the tonsil, the ipsilateral tonsil, and there was no concern whatsoever. We palpated it, felt great. It was pristine, symmetric to the contralateral side. And I had been on a streak of negative DL tonsillectomy basive tongue excisions. 4 or 5 patients prior to that all had come up with path negative for the primary tumor. And so at that moment, I honestly just considered skipping the tonsillectomy because I was on a losing streak. But I had been reading about cognitive biases and the idea of and concept of gambler's fallacy or hindsight bias, where we allow past events independent past events to have an influence on our present decisions kind of stuck in my mind. And so we decided to just go ahead and do the tonsillectomy per guidelines. And of course, the path report came back and there was cancer there. And the point of this is not that we found the primary tumor, which was honestly luck, but the point is that we made the right decision regardless of the outcome in accordance with the guidelines rather than being swayed by our cognitive processes. Another strategy is something called forcing functions, which are essentially rules that force us to consider alternatives. A really simple example of a forcing function that we commonly employ in our field is whenever we take out a foreign body in a patient, whether it's in the ear or in the airway or anywhere else, we always force ourselves to look one last time and just make sure there's not an additional foreign body. So we don't just foreclose our search pattern when we get the initial foreign body out. And other examples of kind of forcing functions that have been proposed are multiple patient visits for the same issue in a short period, even if it seems like a straightforward diagnosis, is probably an opportunity to switch to that system 2 thinking and make sure we're not missing something. And metacognition can help us identify flaws in our decision making and develop some of these specific rules and strategies so that we can avoid errors from happening in the future. And if we employ methods like the human factors analysis, we can kind of pick up on some recurrent cognitive processes that might be occurring and devise systems that can protect us and our patients from them. And the last strategy I'm going to talk about related to cognitive biases is actually emotional intelligence. And it may seem a little bit strange to bring emotion into a discussion about cognition, but in fact, this is actually one of the most consistently identified strategies for mitigating fundamental attribution error. And 3 of the strategies that have been proposed specifically around developing emotional intelligence are self-reflection, active listening, which can help build empathy for team members, and we'll talk a bit more about that in the next section on teamwork, and 360-degree assessments, which can reveal areas of blind spots. And I know this is something that our department, at least on the resident level, does use. We receive evaluations not only from faculty and other residents, but also we get evaluations from clinic and OR staff, nursing staff, even patients. And lastly, another tool for mitigating fundamental attribution error is to focus on objective facts rather than the emotional response to a situation, which is, again, where I think that emotional intelligence and regulation piece comes into play. So we're going to shift gears a bit now and bring some of the lessons about fundamental attribution error and cognitive biases to the team level and talk about teamwork, communication, and safety culture. And I want to talk about a fascinating series of events that occurred on March 30th, 1981. I don't know if anybody recognizes this date offhand, but this was the day where there was an assassination attempt on then President Ronald Reagan. And there's a really riveting article in the Washingtonian magazine that was published a few months after that event that goes through what the medical team did that day and in subsequent days during the hospitalization to save the president. And it contains extensive interviews with the medical staff, and I think it also contains some real instructive wisdom about teamwork. And so the president was rushed urgently to the George Washington Hospital emergency department, and he was taken to the trauma bay, and they identified a gunshot wound beneath the left axilla. They put in a chest tube, and there was blood pouring out. They got over 1 liter of blood out. And so they rushed the president urgently up to the operating room with Dr. Ben Aaron, who was the head of the cardiothoracic surgery at that time, to try to find what was injured and control the bleeding. And when they took the president up to the operating room, there was a crowd of attending surgeons there who were all ready and willing and interested in assisting Dr. Aaron with this case. And he made a very surprising decision, which was he decided to operate with his thoracic surgery fellow and the general surgery intern that he had been operating with that week. So in other words, the usual team. And even more interestingly, after the case, post-operative care of the president was assumed by the resident team. And he makes a very specific point of that in this article. And there's a quote from it: although some physicians at George Washington Hospital felt this was a mistake and that a large team of senior specialists should have been assigned, the more standard approach was taken. And so this story resonates with me for a couple of different reasons. The first is that I think we all have memories of when we're on a team and everybody is just clicking and jiving and we basically achieve a state of flow, but in a group environment. And when you read about the trauma team which was really just composed of a senior trauma resident and a general surgery intern that evaluated the president in the trauma bay, when so little was known, you really get that feeling of a well-oiled team working together. And the second is that as a resident, I find it frankly inspiring that the care of the President of the United States was entrusted to a resident team. They rose to that challenge. So teamwork is key. The literature has shown this time and time again. Teamwork issues were cited as a root cause in 70% of sentinel events. And improved teamwork has been shown to result in more consistent error reporting across medical disciplines, increased patient rescue from major surgical complications, decreased readmissions, which we'll talk about in the final section, and improved work satisfaction, decreased burnout, and decreased turnover in staffing. And going back to the cognitive bias topic, groups have been shown to behave more rationally than individuals, thus checking against some of those biases. So since we're in the Silicon Valley and we frequently talk about collaborating with the tech industry, I figured I would use a study from Google to illustrate this point. So this was an over 2-year study. They looked at 180 teams at Google, 250 different attributes to these teams, interviewed more than 200 people, and they came up with 5 attributes to a high-functioning team. And those were psychological safety, dependability, structure and clarity, meaningful work, and impact of work. And now, I think the good news for us in medicine is hopefully we get the latter 2 of these. Hopefully we all find that our work is meaningful. We feel like our work is high impact and it makes a big difference in patients' lives and families' lives. But psychological safety was actually kind of the overarching attribute that they identified in all of this. And it really, from psychological safety comes dependability, comes structure and clarity. And so I want to explore this concept some more. It's defined as a shared belief that a team is safe for interpersonal risk-taking, and it involves creating a space where people feel comfortable speaking up and sharing their ideas. So there is actually a scale for measuring psychological safety, and that's what I've put up here. The survey is typically given as a 5-point Likert scale from strongly disagree, neutral in the middle, and strongly agree to each of these statements. And we're not going to actually take this survey right now, but I would like for everybody to just take a look at some of these questions and think about what you might answer to them. And how does that answer change, perhaps based on context, whether it's clinical, research, department level, and then also think about how members of your team, particularly those kind of more junior to you, might answer these questions. And I think it's important to acknowledge that just like how cognitive biases are exacerbated by stress, sleep deprivation, and so on, so too is it easy for us to shut down and take on a more authoritative leadership style under these conditions. And I know we've all had times where we've spoken perhaps more harshly than we intended or shut down the debate kind of more vehemently than we planned. So it's all well and good that they studied this at Google, but how do we actually apply this to medicine? Well, actually, the seminal work in psychological safety has really been done by Dr. Amy Edmondson, who's in the Harvard Business School. But most of her work has actually been done in the healthcare setting, and that includes her PhD thesis on this concept. And so for her PhD thesis, she did a study of 8 different nursing units at 2 different hospitals. And the independent variable in this study was team performance, and it was based on surveys and sociological observation. And the outcome they looked at was the rate of potentially harmful medication errors over a 6-month period. And they used both chart review, but also they relied on staff reporting of near misses and errors to arrive at their outcome measure. And the results were initially very surprising to Dr. Edmondson, because what they found was that paradoxically, there were higher rates of medication errors on the units that scored highly on teamwork. So that's a bummer. Maybe teamwork isn't all that it's chalked up to be. But when they actually dug into the data further, what they actually found was that first, interceptions of errors were more common in units that scored highly on teamwork metrics, meaning people were actually recognizing the errors that were occurring. And secondly, people were more willing to speak up about them. So in environments in nursing units where there were punitive measures taken for speaking up about errors, of course those were underreported, and of course that's why groups that scored poor on teamwork concepts tended to not report and discover as many errors. And this data has been replicated in the physician side as well and on the resident side as well. And there was a 2016 study of over 100 residents across medical and surgical disciplines at one institution, and it found that psychological safety directly predicts resident reporting of adverse events. And speaking honestly from my own personal experience, this is true. Not necessarily with event reporting, but I must say, despite my best efforts and a strong personal commitment to patient safety work, there have been certain clinical situations where I've either chosen not to say anything, or maybe I only raised an issue once, but decided not to push it, even though I was concerned. And I think this is more prone to happening, especially when you're at a junior level, when you're a medical student or a junior resident. And so the question is, how can we do better? Well, in an ideal world, it might be preferable to have fixed teams, but that's just not feasible in modern medicine. Surgical teams are fluid. The anesthesiologist changes many times during the day. The OR nurse circulates in and out. Floor nurses change. Residents rotate in and out of rotations. And everybody comes from a different experience level. So how do we maintain a high-functioning team in an environment like this? There's 3 strategies that I'm going to go over for this. The first, described by Dr. Edmondson, is the central concept is that leadership sets the tone. And the way that leadership can set the tone is through 3 steps. The first is to frame work as what's known as a learning problem. And what that means is being open about the complexities and uncertainties involved in the situation. An example of this might be a patient with a difficult to treat refractory problem where there's no straightforward answer on how to address it. And the way to frame that as a learning problem might be to just say, this is a tough situation. We've tried so many different treatments. We're going to have to get creative to solve this. And that kind of statement can really bring in more team input. The second is to acknowledge your own fallibility. And remember the fundamental attribution error, which is there's a tendency to explain away our own mistakes or to blame them on external factors, other team members, the environment, and so on. But by acknowledging our own fallibility, we allow team members to be more vulnerable as well. And if it's any consolation, there's a very interesting psychological phenomenon called the pratfall effect, where people who, if you're considered a generally competent person, you make a mistake, your interpersonal appeal and likability actually increases. So perhaps some added incentive for owning up to our errors. And the third is to model curiosity and ask lots of questions. Soliciting opinions from everybody in the group helps avoid groupthink, and it makes team members more likely to speak up. The second concept is to move from teams, which is kind of the traditional static team model where you just have a defined number of members and persons on your group, to teaming, which is where you have a rotating cast of characters and you have to rapidly get everybody on the same page and the same side. And there's actually some really quick, easy to implement strategies, some of which we do already in our department to do this. One really common example that we're all familiar with is the surgical timeout. But I came across some very interesting research that was trying to figure out, why do surgical timeouts work? Is it the checklist? Is it the items that we go through? Like, what is it about them that helps prevent errors? And what they found is actually, it's not necessarily because errors are caught from running the items on the checklist, although that does happen sometimes. It actually moreover might be that it allows people to introduce themselves by name. And so everybody knows the other person by name during that operating case. And what they found is that just knowing somebody by name improves teamwork and increases the willingness to speak up. And a real-life example of this is the AM huddle that was implemented at Packard recently. And so there were 7 serious patient safety events occurring in the operating rooms over an 18-month period. And they implemented the AM huddle, which is essentially before the cases start in the morning, the circulating nurse, the anesthesia team, and the attending surgeon all gather in the operating room to go over all the cases for the day. And after they implemented that, they found that they've gone over 500 days without a serious adverse event. And then the last thing is crew resource management training, which is basically strategies to help people develop a wide range of skills from standardized communication, situational awareness, decision-making, and collaboration in team environments. And there's great data to support this. At UCSF, they did a project called the TOPS project modeled off crew resource management, which was a 4-hour curriculum in internal medicine units. And they found prolonged improvement even at 1 year on several key measures, including communication openness, handoffs and transitions, and non-punitive responses to errors. And one really commonly employed model of this medical training is Team STEPS, which is a joint collaboration between the DoD and the Agency for Healthcare Research and Quality. And it's an off-the-shelf trainings module, and it includes many kind of pre-built tools and strategies for teamwork. I know that at Stanford, members of the Resident Safety Council can undergo so-called kind of master training in this so they can bring that to their departments. And I know that the Stanford Neurosurgery program has led specific teamwork and safety culture workshops for their residents. So lastly, I'd like to expand our focus to talk a bit about systems level issues and specifically transitions of care. Now, this is a huge topic, of course, so I'm going to be focused in this talk really on discharges. And I'm just going to start with perhaps a trivial but a very common example. So this was a 32-year-old Cantonese-speaking gentleman who underwent routine sinus surgery and presented on post-op day 1 to the emergency department for fever. And he got to the emergency department, and the ED, seeing a fever, ordered a full sepsis workup, and they started IV antibiotics on the patient. Now, eventually this was discovered, and the surgery team became aware of this, and the patient was discharged without event and did just fine, didn't develop any infections. And in looking back on this case, the discharge instructions, they clearly state that fever in the first 24 to 48 hours is normal. And the instructions, they were provided in English, but they were reviewed by the PACU nurse with an interpreter. And I think, again, going back to fundamental attribution error, I think it's easy in these scenarios when a patient doesn't follow an important instruction, to blame the patient or to just explain away this event as they just didn't pay attention. But I think this response can obscure potential solutions. And I will say this is not exclusive to the language barrier. In the past month alone, I've had 2 friends of friends who are highly educated, albeit non-medical people, reach out to me after undergoing common otolaryngology procedures with very basic questions that I'm surprised they didn't know the answers to. Like, one person had undergone a FES and wasn't sure when to start sinus rinses, and another had undergone a UPPP and was concerned about their pain while swallowing. So before we dive a little further into analyzing that example, I just want to describe what transitions of care are. Transitions of care are any movement of patients between different healthcare settings. And so this can be anything from a discharge to ED to inpatient transfer, ICU to floor transfer, care facilities to the hospitals, or even outpatient setting transfers, like getting a referral from a primary care provider's office to go to a specialist's office. And the reasons that this is such a risky period is because there's a high risk for information loss. And in addition to that, there are changing responsibilities that occur between who is responsible for that patient's care. And so to bring it back to discharges, I feel very strongly that this is the highest risk period in a patient's postoperative recovery. Because the care team transitions from basically like a small army of the resident team, attending physicians, nurses, PT, OT, speech, nursing assistants, so on and so forth, to really just the patient and their family. And it's a tremendous volume of information for the patient to digest. And what's more, it often actually falls on the most junior member of the team to coordinate. And readmission rates and ED visits are significant in our field. Our department actually does better, quite a lot better than the published kind of national statistics, but last year our department averaged a rate of 5.7% for readmissions. And if you look at other studies that have looked nationally, they found anything from a 8.4% of ED visit rate after all comers for otolaryngology procedures. And another study using a nationwide readmissions database actually found rates as high as 11.6% after endoscopic sinus surgery. And as an example of how this care transition can be so overwhelming, Another study found that laryngectomy patients in particular are the most likely to return for readmission. They have a 5 times higher rate of doing so when compared to all other otolaryngology patients. And interestingly, what they found in their study was that they are most likely to return on post-op day 1. And the reason that the authors speculate this was occurring is because it's such a steep transition to leave the hospital, now be out in the world as somebody who's totally aphonic, essentially, and is a total neck breather. And so going back to discharges, if you're a resident, you're likely very familiar with the occasional email from the administration at the hospital telling you to urgently prioritize discharges because the hospital is so full. And I think, I always laugh at these emails because, from the resident standpoint, just how many people are involved in the discharge process. And if there's any doubt that discharges are a team sport, this diagram is from a paper that sought to map out the interpersonal interactions in the 24 hours preceding a discharge. And as you can see from this very messy diagram in this paper, it is quite a complex web of interactions involved. And so it really is a team effort to get a patient safely discharged from the hospital. Just to present a little more data on discharges, patient perception of discharges deviates quite significantly from provider perception. Within 24 hours of same-day surgery, one study of 750 patients found that at least 10% of them had not followed at least one key discharge instruction. And in a survey conducted of 99 patients and their corresponding attending surgeon, 95% of physicians thought that the patients understood the activity restrictions, when only about 50 or 60% reported actually understanding their activity restrictions. And so let's go back to the original example in this section on the patient who returns to the hospital because of a miscommunication around discharge instructions. Now, of course, there are many kind of complex interventions that we could propose and conduct, but like I said at the beginning, I want to focus on easy to implement solutions, and many of these have already been implemented by some of the divisions in our department. One is standardizing discharge instructions. Several of our services, I know, have discharge instruction templates, which eliminates relying on any one team member like the junior resident to develop their own instructions, which may or may not be consistent with what the attending provider wants. Translation of common post-op instructions into the most used languages. Our population in the Bay Area is very diverse, and I know that LPCH offers translations of written discharge instructions, but that's a resource-intensive task. It takes quite a lot of financial and staff resources to be able to do that. But many divisions, including those on the adult side or at Santa Clara Valley, have translated the instructions for the most common procedures into Spanish and Vietnamese, which are the most common non-English languages spoken by our patients. Another thing that has been consistently found that I know that many of our divisions do is reinforcing key discharge instructions across multiple encounters. And so many of our attendings have a dedicated team member who meets with patients in the pre-op visit to go over the instructions. And lastly, there was kind of an interesting modification on the the post-discharge phone call strategy. This was a trial out of UPenn, and it showed that a post-op phone call from the attending surgeon or the attending surgeon's nurse practitioner with the option to video conference or send photos of the wound if there were concerns resulted in a 22% reduction in ED visits. And the only intervention required in 85% of those calls was actually just reassurance. So it's not so much that they were actually catching problems that were happening, but they were able to make sure that patients understood the instructions and make sure that patients felt reassured and safe in their care. And of course, there are many similar programs at many institutions, including at Stanford, where I know that patients do receive a post-operative phone call as well. So before we kind of tie everything together, I think there are a couple of common concerns that always come up with any patient safety quality improvement talk. One of them, of course, is, does this mean there's no personal accountability? Are we just spotlighting factors outside the individual and ignoring the fact that sometimes people make egregious mistakes? And I think it's important to distinguish between a no blame culture, which is really just not credible and doesn't make sense, to what I think is the better option, which is a just culture, which is a culture where there's an atmosphere of trust in which people are encouraged to provide essential safety-related information, but in which there's also clear lines drawn about what is acceptable and unacceptable behavior. And I'll talk a little bit more about one way that we can distinguish that in the next slide. The second kind of common concern that always comes up with any intervention is this going to mean more work for us? Which is a very reasonable concern, given how busy we all are. And I think it's very important to be thoughtful about our interventions and to recognize that a major determinant of the success or failure of a patient safety intervention is probably the time cost. If something takes a lot of time, it's going to get ignored or it's going to get shortcutted, and it's not going to be very effective. There is an algorithm on how to respond to provider actions, and essentially what it has you do is you subcategorize that action into, did it result from either a malicious intent or from impaired judgment? And if so, and by impaired judgment they mean, under the influence of substances or that sort of thing. And if so, then of course that's inexcusable and that needs to be dealt with and addressed. But a number of actions may actually be the result of what anybody might do in that situation due to systems level factors. And so just because an action seems risky or reckless, discipline may be warranted, but it's also important to consider this question, which is, would 3 other providers with similar skills and knowledge potentially do the same thing in a similar circumstance? Because oftentimes when errors are made or an action is performed, it's because there is something in the system or the environment that is incentivizing that action. And to really address the problem, you have to find the root cause. And so this moment of reflection can help create that space rather than just jumping to blaming the individual. So we've covered a lot of ground during this talk, and I hope that I've shared how understanding our cognitive processes can be a powerful lens by which to evaluate clinical practice. Cognitive biases like fundamental attribution error also impact how we function on the team environment. And the counter to this is to really develop effective team dynamics to mitigate bias and errors. And as we expand our focus to a systems level to look at care transitions, I think it's important we recognize that how we perceive individual patients, for example, through fundamental attribution error, can also affect our willingness to see and identify areas for improvement as well. Moreover, I think it's important to recognize that care transitions are really a team effort, and they require coordination between many different people and many different care specialties in medicine. And so my goal with this talk is I hope I've shown how opportunities for improvement surround us in everyday clinical encounters. And I hope I have been able to demonstrate, at least to some extent, how small, easy to implement strategies like metacognition or creating more open teams or optimizing our discharge via templates or translation can make big differences in the care that patients receive. And I want to emphasize that patient safety work can occur on many different levels, from the individual all the way to the system. And my closing message for the residents and the department as a whole is really that it can be so easy to be discouraged by the everyday inefficiencies or issues we witness in the system. But I think the most empowering thing we can do with that is to take those issues and to convert them into action. And so with that, I'd like to thank you all for your time and attention. I welcome any discussion from the audience. I just want to acknowledge Dr. Balakrishnan, who provided some very helpful feedback and comments on this talk. I also want to acknowledge my wife, Dr. Gorakanti, who has had to listen to this many, many times, and all the residents and attendings who have led the way through example. I'm happy to share my slides, and I have some interesting resources and articles here, and this is my full reference list. Looks like Dr. Trong asked, how does one build trust in a big department like this? I think that's a great question, Dr. Trong. I think, as Dr. Edmondson talks about in her research, trust really comes from the leadership level. And so I think as residents or APPs or providers in the department are able to see an honest and open exchange of ideas coming from the faculty level, I think that would really help promote an atmosphere of trust and openness. And in addition to that, I think our department does try to bring everyone together in certain events and meetings that really help promote that sense of camaraderie. And it's when we feel comfortable with other people that we can really develop that sense of trust.
Nilesh, it's Karthik Balakrishnan. That was an awesome talk. Thanks for covering such an important set of subjects. For those who are interested, Dr. Ahmad has been doing a lot of work on psychological safety in our division and soon to be in our department, I believe. So there's more to come there. One quick question for you, Nilesh, I guess, is as you head off, as you match into fellowship and finish your chief year, eventually and head off into practice, what specific practices are you going to take with you that you're going to try to implement to put these things into actual operation?
Thanks, Dr. Balakrishnan. That's a great question. I think some of the biggest takeaways that I learned from researching this talk is just how important it is to be open and honest and vulnerable, particularly with those who are kind of looking to us to lead. And I think that willingness to kind of acknowledge when we've erred or acknowledge when we're uncertain is kind of one of the big takeaways that I'll carry with me into fellowship and into my career. I think Rustin had a question. He was asking about, in terms of group dynamics, is there an optimal number of people on a group? That's an excellent question. I'm not sure what the optimal number is. I can imagine that if you do exceed a certain point, then you have to kind of shift your organizational system. And I think it's not just that groups are not automatically better than individuals. I think there is the phenomenon, of course, of groupthink, and so if everybody feels like they have to look to one person when they make their decisions, or then you can lose some of the benefit of being in a team environment. And so it's important to think about the atmosphere and the culture we create as well when considering group dynamics. All right, thank you everyone. Have a good night.